Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. Some women have it easy in their reproductive life and health, while others encounter challenges. It is helpful to know exactly what one is dealing with so as to take necessary action early in life. Endometriosis is one condition which, according to the World Health Organization, affects about 190 million girls and women of reproductive age worldwide. It is a condition in which tissue, similar to the lining of the uterus, grows outside the uterus. This can cause inflammation and severe pain in the pelvis. My guest is an obstetrician and gynecologist with the Lagos State Health Service Commission, Dr. Adewale Adesanya. You're welcome to the show, sir.
Thank you very much. Thank you for having me.
Pain and inflammation sound so much like a menstrual cramp. So how does one differentiate between endometriosis and a menstrual cramp, which most women will just say, well, it happens every month?
Okay, thank you very much for the question. Like you rightly said, endometriosis is the presence of the endometrial stroma and the glands outside the uterus. That thing is meant for the lining of the uterus. So once you have it outside, it around a lot of reaction, activities around that area, and that is why the pain, comes. Now, differentiating between menstrual cramps is a challenge not only for the patient, sometimes for the doctors. So that's why generally it can even sometimes take up to 7 to 8 years after the onset of the symptoms before the diagnosis of endometriosis, which more often than not is usually even incidental finding while you are trying to investigate other condition.
Okay.
You understand? So, but notwithstanding any form of pain or complaint you have as a young lady, it's very important to present to a doctor who will most time refer you accordingly when they are not very clear. I'm assuming that this is not one of the reasons we are having so many ulcer. Because in our environment, you see a lot of people say, I have ulcer. You evaluate and check, you discover that these are pains they look for everywhere. They can't find the cause, and they assume it's just ulcer. Because at the early stage, when you do some of those investigations we do, when you check, you will not see anything on ultrasound scan, for instance. So the person just begin to wonder, so why is this pain? Most likely it's ulcer. So when patient presents...
Are you saying that people with endometriosis have thought that they have an ulcer?
It's like when a patient presents to some people, and they present with pain, they evaluate, they check everywhere.
And they just say
because of limited resources in our environment, they cannot scale it up. At times, when the symptom is not so debilitating, maybe at the early stage, maybe when you have some minimal, because there is a grade of endometriosis, you can have a minimum according to the American Society of Reproductive Medicine classification. So you can have it minimal, you can have it mild, you can have it moderate, you can have it severe. So minimal at times, they don't even hold they have anything. They don't even have symptoms.
And so there's misdiagnosis.
So when it's mild, they have some sort of symptoms, So those are the ones. And when it's persistent, then they present in the hospital. And then when they check, you try to evaluate, look for reasons you can see. I'm talking in our environment now. They are quick to switch to peptic ulcers, and at the same time, when I have a patient who says, "Do you have ulcer? Have you checked?" What a confirmation, more often than not, they don't really have.
This condition happens to only the female gender.
Exactly.
Okay, what do you do to make an affirmative definition diagnosis?
So talking about, we're moving to diagnosis now. So Diagnosis as a clinician, you need to go through the history. There's usually a pattern.
Okay.
No doubt about the fact that I said earlier on that it can also confuse health practitioners because they have some similarities with some other condition. Like, for instance, a patient who has endometriosis can present with Mitchell-Schmerz pain, like ovulation pain. They can present with something that's similar to premenstrual syndrome. They can present with some wide varieties of symptoms that you can see in other conditions.
What are these symptoms apart from the pain?
Okay, now, we have not even defined the pain. Pain can be from any part of the body, depending on which organ of the body is affected by the endometriosis. So you can have, it starts from maybe dysmenorrhea, that is painful menstruation. Dysmenorrhea can be primary, can be secondary. We always say when it's primary, it's usually mild and not so significant. But when it's secondary, there's usually an associated pathology. And one of those kind of pathologies we're talking about is this endometriosis. So they can have severe dysmenorrhea. They can have dyspareunia. That's when you have intercourse and you're having pain.
Okay.
I need to differentiate between what we call superficial dyspareunia from deep dyspareunia. This is the one that is more associated with endometriosis is deep dyspareunia. I know most of our ladies will be able to relate and they understand when it's deep and when it's superficial. However, in some few instances, you can have superficial when the nodules of the endometrium, you remember, we say outside the uterus. So it can also find its ways to the entrance, the cervix, or even the walls of the vagina. So when you have it there, you can also have some occasional superficial dyspareunia. So that's still talking about pain, you understand? So you can have, most of the time, they can present also with infertility, subfertility.
You've hit a nerve.
Subfertility. So those are the classical symptoms of, and I must state here that in majority of cases, that's why it's not very clear the total number of people that have endometriosis. In majority of cases, they don't even have any symptoms.
Okay, so in the cases where there are no symptoms, do they still have challenges with having a pregnancy?
Yes, at times they can have challenges with.
Can this endometriosis be prevented?
So now that takes us to the etiological factors of endometriosis. Now, when you look at, when I say etiological, let me bring it down. Things that cause it. It's even largely unknown. There are just theories. That's why I say it does not create headaches only for the patient, and sometimes it creates for the medical practitioners. So there are theories. Some will tell you that it's as a result of retrograde menstruation, like, okay, the menstruum, that is the blood that comes during menstruation,
goes back,
trying to find its way, but can't get out, but it finds its way into the peritoneum. And peritoneum is such built that you don't want anything, foreign thing, to come in there. They trigger, they can trigger reaction in different form. So there is what we call Samson theory. That's the one that, founded the fact that it's as a result of, a lot of people came up and said, okay, why do we now find it also in people that are menstruating heavily? Yes, they still have endometriosis. So that means that theory alone cannot explain.
It cannot carry the whole thing.
So then it takes us to another theory of coelomic metaplasia. So there are different theories.
Use simple terms for the viewers.
As in some, during their biology formation, there are things that multiply, so maybe one of them just got out of
hand
control and started multiplying excessively.
That sounds like cancer. Can it cause cancer?
No, not necessarily cancer now.
Okay.
In a region where it's not supposed to be.
Okay.
So now, above all of that, there is also the genetic angle. It's such a confusing condition that we cannot even pinpoint one particular gene accounting for endometriosis. It's usually a constellation of different types of genes.
Okay, so apart from being a woman, Are there other risk factors for endometriosis?
So age has been, fingered as a risk factor. Then,
so the older, the more.
Thank you very
possible?
much. Also, excessive body fat. Excessive body fat, and anything that allow you exposure to your estrogen hormones for a longer period. Let me break that down. For instance, if you are the type that have a short cycle, for instance, the average length of cycle or the normal length of cycle ranges between 22 to maybe 35. Okay. So if your cycle falls short of 22, you're at risk.
Because you are more estrogen.
Now, if you want to celebrate that, okay, mine is 28, mine is 30. If your period is also longer than 7 days, that means you are exposed to prolonged menstruation. The normal range for that is 2 to 7 days. So you are bleeding for more than 7 days.
So that's a risk factor.
You are also at risk. Are you getting?
Okay.
Okay.
Is it hereditary?
Okay. You didn't allow me to finish that. Should I continue or I should answer that first?
Let's move on because you won't have enough time to go.
So I talked about genetic the other time. So there are facts about the link between a woman who has endometriosis and the first generation. First generation, first relative. It is four times common among them. Compared to the
children.
Yes, our children, our siblings, and all the likes. So they have 4 times chances of having it compared to the others. So we can still,
it's still familiar.
Point at, genetics.
Okay.
There.
So what are the implications of this?
I don't know if I should answer your preventive measures. So when you talk about prevention, if you don't have power over your genetics, you don't have power over how your body controls your timing, then you need to work on your environment. What can reduce your amount of the bulk of fat in your system? How can you regulate your own cycle? There are a lot of things you can do in anticipation to regulate that. However, there is no evidence that has suggested that any of this has been able to change the natural history of endometriosis.
So it's still a very speculative area of medicine.
Exactly.
Okay. What are the implications to a woman in her reproductive life? I know you've mentioned infertility, or at least difficulty with pregnancy. Any other things? So
that's very important or very critical, especially in our environment. We so much value that aspect of our life. So the other thing is when it's severe, when it's debilitating, you feel sorry for whoever has endometriosis. So the pain is even very significant. That person at that time is not even thinking of conception. He's thinking of how do I improve the quality of my life? How do I live a good life? So it can be very, very disturbing. So apart from infertility, that's another thing that it presents with in a woman.
You can call if you have questions on this topic, 0808-054-2233, or send a message at CTV_Mary A, or send me email to moalale@channelstv.com. We've heard that this condition cannot be cured because they don't even know how it starts, the etiology, as you said. But can it be managed?
Most definitely.
To give the person some sort of life?
Most definitely.
Okay.
So that's the beauty of presenting on time to your gynecologist. It's as good as even where there are limited resources, gynecologists can actually refer to another gynecologist to take adequate and proper care of the condition.
So the pain will reduce?
Most definitely. There are different modalities of managing this condition.
The big question which I have to ask is, can the woman get pregnant?
Yes, that's, our management is usually, when we want to treat, when we want to manage, you want to know what are we treating exactly? Because managing endometriosis is usually individualized.
Okay.
What are we treating? Are we treating the symptoms? Are we treating the condition, the disease, or are we treating them both?
Okay.
So
now, for a woman,
yeah,
her major problems will be two from what we've discussed.
Well,
get me out of this pain and I want to have a baby. Okay. So let's assume that's what we're doing in this case. Is it possible? So
it's quite possible, but it defines the history, the pattern of the disease, and the severity will define a previous treatment, the resources available, evidence will define the kind of care she gets.
Can this endometriosis, can it be operated and removed?
Most definitely.
Okay.
Most definitely.
News is getting better and better.
Most definitely.
Okay, so let's say a woman is pregnant.
Okay.
And she has endometriosis.
So,
what are the implications for the pregnancy?
That's one of the beauty of nature. During pregnancy, endometriosis is silenced.
Perfect. It's not like the fibroids. We heard that fibroids sometimes grow with the pregnancy.
During pregnancy, fibroid is also silenced, but there is a period where the fibroid respond because of the hormonal milieu and the changes in pregnancy.
Okay, but in endometriosis,
it's supposed to be silenced.
Wow.
In fact, that is why one of the risks is when you have reduced parity.
What does that mean?
Those that decide not to get pregnant, not to have babies, or I just want to have one.
Okay.
That affords you a prolonged exposure to this implicated hormone, most especially estrogen.
Okay.
So when you say, I just want to have one, okay, I don't even want to have babies, so you're at risk of having it. Do you understand? So that's one of the
pregnancy is kind of like
it's like you are going to silence it for like 9 months.
For 9 months, which is great.
I need to even state that one of the drugs some of the drugs, especially the hormonal drugs, the concept is to even mimic pregnancy state or
to deceive the endometriosis.
That okay, you are in a
quiet.
That's the best way we can explain for people to understand. So, or a menopausal state where the estrogen are, they are not functional or they are not really working as such. So most of those drugs are built to do that.
Okay, so that brings me to my next question. Does a woman with endometriosis suffer it throughout her lifetime?
So, okay, it is more disturbing during your reproductive age. That's from puberty to menopause. However, if he has left a debilitating condition, remember you said at the beginning, it causes what we call fibrosis and adhesions. So this has a distorting effect on the pelvic organ, the organs that are, living in the pelvic region, the ovary, the tube. So if he has left something that has affected other organs, and you're not addressing it, you're not treating it. After your menopause, when you enter your menopause, when you are supposed to be relieved of the pain and other associated symptoms, the effect, the adhesive bands, the fibrosis, other things they has touched on may start now, disturbing.
So the trick is to find it early.
Early and manage it.
And manage it.
Absolutely.
Okay, I want to know, definitively what you are saying. Because a lot of girls have menstrual cramps.
Okay.
If a girl starts to have a menstrual cramp, maybe she's having a period for the first time, do you advise she see a doctor just to find out, just to know what's going on, or just assume, well, that's what happens to other women and leave it there?
So generally, I've done some interview or video where I was asked when is the best time for a young lady to get close to a gynecologist. It's even before you start menstruating.
What would she be discussing with you?
It educates you. When knowledge is power. When you have knowledge, you have control over your body. You have an idea of, you can relate with your system, you can relate with your body. So I would say before. Now, if you start menstruating and you are having menstrual cramps, of course, you need to review. You need to see your doctor. The doctor knows what to check and where to check to be able to differentiate between the one that is just, is just natural from the one that is pathological. That affords you the opportunity to address it on time, if you are interested, because most of the time we do what we call patient-centered care, if you are interested in addressing that at that point.
Okay. So it's important to address it early so that the symptoms will reduce and perhaps there'll be a better chance of pregnancy.
Yes, of
And
course.
also so that when it is supposed to be silent at menopause, that will happen as
That
well.
will happen. So you won't have to manage the consequence or the complication that arise from the period you abandon the condition and it got worse.
Okay, so from what you've told me, there are different types of endo.
Yes, of course.
Are there some that cannot be treated?
They all can be managed. Studies have shown that when you excise them with a good range covered during your excision, you can conveniently relieve symptoms and improve quality of life, also improve chances of conception, be it natural or assisted reproductive technique. You can improve all of that. But evidence are bound that you can still have some recurrence here and there.
At least I'm glad to hear that such a woman can have a baby.
Of course.
But if infertility is a problem because of endometriosis,
yeah,
treatments usually involve estrogen. So
hormones,
I'm trying to understand. Okay,
not necessarily
estrogen.
Hormones. Okay.
Because estrogen would sort of excite and trigger the endo.
Yes.
But it doesn't have to be estrogen for her to get pregnant. Does she need to be assisted to get pregnant, or they just need to treat the endometriosis?
So now that's also bringing it into perspective. That's why I said earlier on, the cases are usually individualized. So there are some that are subtle, that with little assistance there and there, just stimulation or timed intercourse guiding them, they are able to conceive. But when it starts involving the ovaries, well, like when you have the particular type we call endometrioma, when the old ovary gather like a cyst of the menstruum inside it, that will require either excision or silencing the ovary for some time before you excite or after you excite. Those periods you are doing those things, the ovary cannot produce egg. So it can be an adjunct treatment to surgery using the hormones. It can be, the hormone can be used to silence the ovary so that it doesn't escalate the effect of the endometriosis. So the condition determines what you do. Studies have shown also that at times excision,
that's
or
removal
of the endometriosis, maybe you are burning it, have a way of reducing ovarian reserve, reducing your chances of even producing egg. So sometimes when you have it and you are managing it, your case is directed.
It's very individualized.
It's very individualized. So sometimes when you have it deep like that, when it's excised, you are advised to go straight for assisted reproductive technique, either in form of in vitro fertilization or any other
within the reproductive
exactly.
Space.
Research has shown that there have been increase in success rate when you actually treat the endometriosis before going for such.
Okay, I have to ask you this before you go. When you were discussing, you spoke about the paucity of instruments, as it were, or resources or technology, whatever it is, to handle endometriosis. Is that the point we are at right now in Nigeria?
Well, if we want to compare where we are now with where we've always been, we can say there is a significant improvement. So, okay, let me just say this now that
because we are looking for hope for our women.
Now, we call it gold standard for diagnosing endometriosis is what we call laparoscopy. That's the pinhole surgery.
We do laparoscopy in Nigeria.
We do laparoscopy, but in how many centers? compared to the number of people that are in need of such and even at what point do they present for them? Most of the time, those who go for this laparoscopy are those that have done all sorts, trying to get pregnant before they get to that point.
Okay.
Do you understand? So there are, I can't mention, but there are lots of centers that where you go and present this condition and they don't even have the laparoscopy facility to do it. Yes, we have a number. In fact, one of the good news is that we even have some excisional surgeons. There are people that are also trained, skilled to excise the endometriosis or endometrioma, as the case may be. How many are there? There are very few. So those are the things I talk about, limited resources. Okay. So you individualize and, help the patient as much as you can.
I have to stop you there. Thank you so much for coming. This has been so interesting. But thank you also for listening in and watching. There's hope for those who have endometriosis. Don't give up. You can get pregnant and you can be free of pain. Thanks for watching. I'm Mary Alale Yusuf.